Okay, so we are almost finished. This is going to be part one, and then there will be a part two. Oh my God. Yeah, this is like, it's been torture for me, guys. You have no idea. Because for each audio, that's like, even if it's like an hour, like literally prep time is almost 3 hours, like just to make sure that either I'm re-recording a slide or I'm anticipating what your questions might be so that I can definitely make it as clear as possible for you. Um, I definitely missed that interaction in the class because somebody would stop me and say, hey, what do you mean by that? Or what do you mean by that? So it's almost like I had to script something just so that I'm answering your questions so that everything you need to know, you know it or you get it. Anyway, so in your Blackboard, there is also like, what is there? There's a PDF that's going to say, I think it says glaucoma on it, but it's just very simple. And it's comparing open angle glaucoma with angle closure glaucoma. So you just pull that out at the very beginning when we get to glaucoma so you can see what the differences are. But I'll go over it now just so I don't forget to do it later. So for open angle glaucoma, the main things that they're saying is that it's 90% of all the cases of glaucoma. So it's the most common type. It is an issue of slow clogging of the drainage canals. So something happens at the trabecular meshwork that is the issue. So, and we'll go over all of this. It'll all make sense. It has a wide angle. It has a wide and open angle between the iris and the cornea. So, because the issue in glaucoma is that either there's some type of blockage that's stopping the aqueous humor from draining, or the angle itself is narrow, it's small, and that's the issue. And that's the one that they will be calling angle closure glaucoma. So, for the one that's open angle, on that you are on that left side of your paper, the main thing is that 90% of people have it, so most people end up with open angle glaucoma. It has to do with slow clogging of the drainage canals, specifically the trabecular meshwork, which we're going to talk about later. It has a wide angle, so the angle itself is okay. It's open between the iris and the cornea, so there's no problem with that. And it's really the trabecular meshwork that's the issue. It develops slowly and is a lifelong condition. So this condition develops slowly and is a lifelong condition. So the patient is basically going to require long-term treatment or treatment for the rest of their life, right? And other words that they may use are things like primary or chronic glaucoma or wide angle glaucoma, all of that. And then even with this particular category, there's also other specifications or categories that they may have. But at the very least, be able to know just this little much, okay? And then on the other side, for the angle closure glaucoma, so it's the closed or narrow angle between the iris and the cornea. It develops quickly, so that's a key word. So it develops quickly, so the key word is quickly. You notice it very quickly, or the patient feels it right away. It requires immediate medical intervention, like immediate medical intervention and attention. They may use other words like acute angle or narrow angle, and it's literally the result of angle. The angle between the iris and the cornea changes, and it's small. And they may use other words like to describe it depending on what's going on. They may say pupillary block. So this, and remember, there are different ways that they can explain all of this. But at the very least, know the differences that under open angle, we're talking about the angle between the iris and the cornea. It's fine. It's wide, it's open, it's okay, but it's the trabecular meshwork that's the problem. And then for the angle closure, specifically, we're talking about the angle between the iris and the cornea. It's either closed or it's narrow, so that's not good. And between the two, the worst one for sure is the angle closure that requires immediate interventions, okay? And then we're going to look in your book here for charts that you need to be looking at. So this is chapter 63. So you have on page 1880 taken a history of patients with eye and vision disorders. So what types of questions are you going to be asking them? And some of this information I'll go over, but I would like you to look at the chart as well. And then we have on page 1886, we have chart 63-3, and this one is strategies for interacting with people who are blind or have low vision. All right, so how do you interact with the patient who is blind or has low vision? That's on page 1886. You are looking at page 1889, and this is instilling eye medications properly. So this is chart 63-4. All right, and on page 1888, there's just medications that you may find for patients with eye problems. Okay, and once again, you're focusing on whatever meds made it on your list, which I don't think you have a list for the final exam yet. I can't remember, but anyway, so that's so we'll see if you need to know those as well. And then on page 1891, you have selected glaucoma types, clinical manifestations, and treatment. So this is where we're talking about the wide angle glaucoma versus a narrow angle. And then you can see that underneath each category, they further subdivide them as well. Okay, so just know that this is out here. And then on page 1893, medications used in the management of glaucoma. Okay. And then 1894, managing glaucoma. So this is patient education. What are you going to be teaching your patient? And then on that same page, 1894, there's risk factors for cataract formation, right? So that's important as well. And let's see here. On page 1897, you have at the completion of education, the patient and or caregiver will be able to do what in terms of taking care of a patient that has had an intraocular lens implant. So this is somebody who's had cataract surgery and they took out the lens and they have an implant. So how do we take care of that patient? So that's an important chart as well. And I think that should be it. Page 1903, education for patients about preventing eye injuries. Yeah, so that's just out there. Okay. All right, so then we're going to talk about, so we're going to start our lecture talking about the eye here. And once again, I'm not spending too much time on the anatomy specifically, except as it relates to, I think when we get to glaucoma and just the different structures that you really need to be familiar with. So this you should have had in bio at some point. You know what a globe is, the eyeball, you know what that is. You don't have to memorize the centimeters or anything like that. But have a sense of, okay, where's the pupil, where's the sclera, iris, eyelids, right? Where's the eyelid? All of that matters in terms of if patients have ptosis, right? Have an idea about the lacrimal glands, what are they supposed to be doing, all right? And then in terms of eye movement, we know that primarily we're focused on cranial nerves 3, 4, and 6, and the other ones that we're really kind of familiar with in terms of eye movement here. All right, so just know that that's out there as well. Tears are formed by the lacrimal gland, and why do we care? Well, they're helpful for eye health, and they're composed of all these different types of tissues and layers, and it basically is protecting the cornea, right? Conjunctiva, we're familiar with already, because when somebody has conjunctivitis, we know that that's an infection to this specific area, right? So conjunctiva is a mucous membrane which provides a barrier to the external environment and nourishes the eye, okay? Sclera is the white of the eye, right? So it's more important that you can visually get a picture and then look at the picture of the eye. So when I'm talking about the different structures in relation to particular eye disorders, that you're able to see it and you can make sense of it, okay? And then the cornea, so avascular dome-like structure forming the most anterior portion of the eye, all right? So cornea, underlining most anterior, okay? and it's the main refracting surface of the eye as well. Then it composed of all these different types of layers. All right, and this one you're looking a little bit more closely now because you want to make sense of some of this stuff. So here you've got your cornea, right? And here you've got your iris, okay? So we already know from what I said earlier that when it comes to glaucoma, right, when we're specifically talking about angle closure glaucoma, we are worried about this angle here. So the angle between the cornea and the iris, right? This angle right here. So if it's angle closure, this is small. The angle is small. So it's less than, I think it's supposed to be 45 degrees. It's less than that. So that becomes an issue. And then we'll talk about the trabecular meshwork for when it's just open angle glaucoma. This angle would be fine. There will be no issue, but the trabecular meshwork would be impaired in some way. All right. The lens is important when we're talking about cataract surgery. All right. And then you have other structures in here like the optic disc, the optic nerve, the macula. We'll talk about that as well. Retina. We'll talk about all of this. Right. So this is the front to the back. All right. And then your aqueous humor is actually supposed to be coming from back here, and then it comes and goes through, it goes to the anterior chamber, and then it drains. Okay. So if there's a problem for the aqueous humor coming out, either because of the angle or either because of the trabecular meshwork, that's why you end up with a whole bunch of pressure in here, and that's a problem. And all of that pressure can actually damage your optic nerve. All right. So all of this will make sense in a little bit. So anterior chamber behind the cornea. So you see your anterior chambers right here, and it's behind the cornea. It's filled with clear aqueous humor. Production is related to intraocular pressure, and is replenished like every 100 minutes. The most important number in terms of you knowing in terms of the IOP, the intraocular pressure, is this number here, 10 to 21. So that's what we want it to be. We don't want this pressure to be elevated. All right, and then just other structures in here, your iris, your pupil, etc. All right, so your lens is enabling focusing for near vision and refocusing for distant vision, right? So it's also doing things like ability to focus and refocus. That's being known as accommodation, if you're able to do that. And apparently accommodation decreases for sure with age. So we know if there's issues with the lens, this is where cataracts is coming in, right? So therefore the patients can't be focusing and refocusing, right? So accommodation is not working. They're seeing everything as being blurred even, right? So we'll talk about that later. And then the retina is an extension of the optic nerve located at the innermost surface of the fundus. Let's see. So your fundus has a whole bunch of different structures in it. Let me just see what I had. Okay, so for the fundus, when they describe it, they are saying it includes things like the retina, it includes things like the optic disc, the macula, and the posterior lobe. All right, so I'm going to discuss the fundus again later. All right, and then just telling you about all the different things that are in there. So the rods in particular, responsible for low light and night vision. So we're able to see in very decreased types of scenarios. And the cones help us to see with bright light vision, and then we're able to distinguish color as well. Okay. Just some pictures here of weird things. All right, how the eye works. So once again, loosely, so your light is entering your eye. Light refracted, meaning bent by the cornea. It's refracted again by the lens. Accommodation is going on. Focusing is going on. So remember, focus, refocusing, accommodation, all that good stuff. And then inverted image sent to the retina. Rods and cones are doing all that. Sensing of the image, and then your brain basically is making sense of what's going on. All right, so no need to memorize, just loosely understand this stuff. Okay, so you end up with vision. That's what you wanted. So a defect or inability for the image to pass through any of these steps leads to a defect in vision, and that makes sense. So if you have issues with the lens, that's a problem, right? If you have issues with too much intraocular pressure and your optic nerve is damaged, so there, that all of that can be an issue. So that's a problem as well. Okay. So what are you going to have? Things like poor visual acuity, defective or absent peripheral vision, partial blindness, or actual blindness. So these are just questions where you're taking an ocular history, right? And so remember I mentioned another one in the book that you can look at as well, if just to compare. And so this is nursing assessment. So a patient comes in, you're asking them questions. So this is what we do, right? So none of these questions should be weird for anybody. So what does a patient perceive to be the problem? Is the visual acuity diminished, blurry, double, or distorted vision? Are there any pain? Are their eyes hurting? Character of pain, worse when blinking? Just asking them a whole bunch of questions. Is the discomfort from itching or foreign body? Both eyes or only one? History of discharge, color consistency, recurrence of previous problems. Has condition affected ADL? So this is huge. What medications are they on? Have they self-treated? That's big too, because patients, depending on where they're from culturally, they'll do weird things too. Any ophthalmic history or surgery, cosmetic procedures, family history, right? So you're asking them very general to specific questions to see what's going on with them. Okay. So we have what is known as a Snellen chart. So this is one way for us to assess visual acuity, right? So your normal vision is considered 20/20, right? So I'm going to explain the Snellen chart in a second. There are different ways to assess your visual acuity as well. You can cover one eye, see if they can see, then you do the other eye, right? You ask them to count your fingers, and then you're basically recording all results. All of that is helpful. So here you have a Snellen chart. So you must understand the Snellen chart. You have to be able to tell me what it means if I say to you your patient has a vision of 20/200. Obviously, that means they can see this, the E, the big E, at the 20 feet line. So I'm going to explain this. So on the previous slide, it said that if somebody has 20/20 vision, so if somebody has 20/20 vision, it means that people or that person can see the letters on the line designated as 20/20 from a distance of 20 feet, right? So when you go to the doctor's office, there's a line that they've designated to be 20 feet, right? It's marked, and they'll tell you to stand over there. And then they're going to have this chart, this whole big thing in front of the patient, right? Like 20 feet away from the patient. They'll have this big chart. And that patient will come in, and they'll have no issue reading line number 8. From 20 feet away, they can perfectly see line number 8, and that's considered normal, right? So 20/20 means that people can see the letters on the line designated as 20/20 from a distance of 20 feet. A person whose vision is 2200, right? So now we're at 2200, this one up here. A person whose vision is 2200 can see an object from 20 feet away that a person with 20/20 vision can see from 200 feet away. So another patient comes in, and you ask them to stand at the 20 feet line, same exact scenario, same spot. You tell them stand right there, and you ask them to read the same Snellen chart. Like, tell me what you can see. At 20 feet, that person is only going to be able to see the letter E, right? But a normal person would be 200 feet away. Like, they would be way, like 20 feet is very close, right? But a regular normal person would be 200 feet away, and they would be able to see the letter E. So that means that the patient that walked in they have very bad eyesight, because at 20 feet, all that they can see is an E, right? But a normal person, they would be far away from the 20 feet, and they would be walking, into the hospital, and they can see the big old E because they can see it, all right? So clearly everything that is going up this way is bad vision. So anything from, not like it's bad vision. I mean, there are different levels of bad, but we're expecting everybody to be 20/20. But once we start going up this way, then our vision, is basically not the best. There are conditions where other people have incredible sight, and they like see things even better than the regular 20/20 person. Right? So we don't concern ourselves with that. We focus on 20/20 and going up that way. So then on the previous slide, it also said that, only you just had that. So another example would be a patient comes in and they are diagnosed, so they're standing at the 20 feet line again. And for them, they can see, they can read the E, F, P, they read all of that. And then they can only get up to here. Like this is as good as their vision is. I'm sorry, I switched it up. Okay, I'm going to make it line number 5. So they can, the best vision that they have is here, 20/40. That's what they have. So that would mean that that patient can see at 20 feet what a normal person would be able to see from 40 feet away. So still, it's still not the best scenario, because a regular person at 40 feet away, they would be able to read this line, no problem whatsoever. But this person has to be at 20 feet in order to read this line. And the way you're looking at this is obviously at 20/20, the letters are small, right? So at 20 feet, you can see this, we're happy. At 20 feet, it's at 20/25, it's like the letters need to get bigger, right? At 20/70, ooh, the letters are really, really big. So that would mean that this patient comes in at 20 feet. This is their best vision. They won't be able to see any of this down here. They can see the big E, they can see the FP, and then right here, this is about as good as it gets for that patient who's 20/70. So that would mean this patient can see at 20 feet what a regular person can see from 70 feet away. All right. So I really do need you to understand the concept of the Snellen chart. It is entirely possible for one eye to be 20/25 and the other eye to be 20/200. So it doesn't necessarily have to be the same reading in both eyes. Okay. All right. So then we're talking about the external eye structures, examinations. You're looking at the eyelids. You want the eyelids to cover the upper iris. You're looking for things like ptosis. Lid retraction is when there's too much eye exposed. So the lids and lashes should have no edema, erythema, lesion, scaling, or crusting. Any tearing or discharge should be noted. There's this funky weird thing known as xanthelasma or xanthelasmata. So this is just yellowish cholesterol deposits under the skin, and we'll talk about this under, I think it's macular degeneration. All right, this is what ptosis may look like. All right, so congenital in a child, older person, ptosis, and other people that I mentioned may have the xanthelasma, that weird cholesterol deposit. So this is a yellowish deposit of cholesterol under the skin. Can be on the eyelids, and it's not harmful at all or painful. It just doesn't look good, so it can also be removed. So people can have cosmetic repair to get rid of it. Okay, here you go. So when people do have this, when your patients do have this cholesterol deposits, apparently it puts them at risk of heart attacks, other heart problems, the risk of dying. And it doesn't matter if the cholesterol level itself is normal or high. Just the fact that they have this under here apparently is a problem. So you don't have to memorize the numbers at all. Just know that this is out here. All right. So here we have different ways of, or one way of assessing the eyes, right? So they can have an ophthalmoscope. Haha. So it's a handheld instrument with lenses that rotate, enabling the examiner to bring the cornea, lens, and retina into focus. And you want to do this at eye level. They're looking at the fundus, And so the fundus should be free of lesions. So remember, the fundus has things like the retina, optic disc, macula, and it's really the posterior lobe as well. You're looking at all of that. So this is on the inside at the back of your eye, this fundus. This is where, when you look at your picture before with the retina, all of that, it's in the back, okay? The optic disc, the way they're describing it is when the optic nerve connects to the retina in the back of the eye. So they're calling that the optic disc. So anyway, so when they're saying fundus, the structures that they're talking about include the retina, the optic disc, the macula, and the posterior lobe. All of that is part of the fundus here. Okay, so though it's a scope, they're looking around, so they may see things like arteriosclerosis. So it's going to look silvery or coppery in appearance. They may see things like red smudges, and that's for intraretinal hemorrhages. All right. Apparently, if it's flame-shaped, then the patient has hypertension. If the patient has hypercholesterolemia, it's going to have a yellowish appearance. Okay. So normal fundus versus hypertensive retinopathy over there. Okay. All right. They have what is known as an indirect ophthalmoscopy. So this one is permitting the ophthalmologist to see larger areas of the retina. So there's no magnification in this type of test. So they're just looking just to see what the retina looks like. And then in the slit lamp examination, with this one there is magnification. Everything is bigger, like 10 to 40 times magnification, so that they can look closely. All right, so just know that these are out here. If you see them, you know that they belong under eye. Color blindness. So this is the inability to differentiate colors. So it's usually genetic, but can be a result of optic nerve damage, medications, and other pathology like cataracts for sure. For color vision deficit testing, they can do what is known as an Ishihara polychromatic plates, and we will look at that. Okay, so this is A versus B. So in A, I see the number 3, no problem. This is 3 right here. Okay. In B, you should be able to see, what is it? They're saying 73. I think I'm blind. I'm seeing 23, but anyway, this should be 70 and 3. I'm in denial about my vision. Oh my God, this is really bad. Anyway, so the transformation plate of the Ishihara in A, okay, normal should see 3, while a color vision deficit person should see 5. At least they should be able to see a 5. I can't see the 5. I guess that's good. And then in the vanishing plate of the Ishihara, normal should see 73, while a color vision deficit person will not read the figures correctly. So obviously I have a vision deficit here. This is not good. I have a color vision deficit. Anyway, so that know that this is out here. All right. And then here you have a question. So the client's vision is tested with the Snellen chart. The results of the chart are documented as 20/60. The nurse interprets this as, so don't get confused between this one and this one, right? So it's not the client can read at a distance of 60 feet. We never reference the second number. We always reference the first number. Do not confuse the two. So the client can read only at a distance of 20 feet what a client with normal vision can read at 60 feet. So vision disorders, so now we will tackle glaucoma, and then I'll probably end it after that one. Okay. So it's a group of conditions characterized by optic nerve damage caused by intraocular pressure, IOP pressure. So this is important to know. It's one of the leading causes of irreversible blindness in the world, and a whole bunch of people are in trouble from it. So increased IOP can be caused by, why would you have an increase in intraocular pressure here? So aqueous fluid inhibited from draining. Remember I mentioned that. So drainage depends on the angle between the iris and the cornea. The angle should be 45 degrees. Narrower angle impedes drainage. So this is an issue for the angle, when the angle is decreased. That's the angle closure glaucoma. So different things can cause problems to increase your IOP. So what do those things include? Things like hypertension, blinking, especially if you're blinking more than normal, or if it's pressurized blinking. Maybe you've had, I know, other issues like brain trauma or something like that. That could maybe come into play over here. Tight eyelid squeezing, same thing scenario with maybe an edematous head from some type of trauma that's going on that's preventing your eyelids just from being normal, right? Uveitis, and the main issue is that with increases in IOP, we get damage to optic nerve. That's the main no-no. Okay, so we're looking at this very closely. So it's the same structures that we had before. So remember your cornea, remember your lens, but for glaucoma, we're looking at the cornea and we're looking at the iris. So here we have the iris up here, and that's fine, but it's the same thing down here. You have the iris, and it's still all about this angle over here, right? So this is your normal eye. You have your optic nerve here. You were happy with that, and we have, let's see. So here they're describing damage to the optic nerve because you have all this pressure that builds up because this aqueous humor is supposed to be going this way and then draining out. All right. And here you have your trabecular meshwork. So remember, if it's open angle glaucoma, the angle is fine, but the trabecular meshwork is the problem. Okay. So we'll talk about all of that. All right, so aqueous humor flows from the posterior to anterior chambers through the pupil and is drained through the trabecular meshwork in a healthy eye. Okay, and we like aqueous humor because it nourishes the eye and it maintains intraocular pressure. All right, so aqueous humor flows from the posterior to the anterior chambers through the pupil and is drained through the trabecular meshwork in a healthy eye. All right, so that's your trabecular meshwork over here. That's what we're talking about. In glaucoma, this normal drainage of aqueous humor slows or is stopped, causing pressure inside the eye to basically build up. Okay, the pressure damages the optic nerve, resulting in vision loss. All right, so that makes sense. Okay. So here they're basically trying to show you a picture of your normal angle glaucoma versus your angle closure glaucoma. All right. So this is referencing also the chart, the little PDF that I gave you. All right. So we know that when the angle is normal, we're concerned about the trabecular meshwork. That's the problem. It's not allowing proper drainage. Okay. And for the angle closure, we're specifically worried about the angle between the iris and the cornea. That is a problem. This is because of a blockage. And we know that the closed angle glaucoma is more acute, is more deadly, all right? So that's really the main difference here. Okay. And that's really, I mean, that's pretty much all I would want you to remember in terms of normal angle versus angle closure. Like, at least be able to explain that to me, okay? Yeah. Then you have your risk factors for glaucoma. And remember, in your book, you have some as well. I think it was page 1890. So things like family history of glaucoma, African American race. So this does become important in terms of patient education. We saw that, what else did we see? We saw that hypertension was a problem, wasn't it, for glaucoma? Yeah, hypertension was also a problem in terms of increasing the IOP. So then that becomes important with African Americans in terms of diet, maybe too much salt. I don't know if that's the direct reasoning. So you know that would matter in terms of race. You want to start noticing that a little bit. Older age, diabetes mellitus, cardiovascular disease, migraines, eye trauma, nearsightedness, which is also known as myopia. So somebody who has nearsightedness can see objects near to them very clearly, but they can't see things that are far away. Things that are far away are very blurry, right? Farsightedness is the opposite of that. They have a problem seeing objects close, but they can see things that are really, really, really far away very, very well. And then presbyopia is another term I'd probably want you to be familiar. Presbyopia. The eyes can't focus quickly on objects, even when they're close to them. Like they can't focus. Okay, so that's an issue or a problem there as well. And then, so the nearsightedness is it's specifically under a risk factor for glaucoma, but I was just defining farsightedness and presbyopia for you in terms of other words that I would like you to know just in general under eye disorders. And then prolonged use of topical or systemic corticosteroids can also be an issue. All right, so they are going to do a workup and they're going to figure out, okay, what's going on, and they're looking at the optic nerve damage. The machine is the tonometry. So you must know tonometry, you must know that it belongs under glaucoma, and you need to know that it is measuring IOP by determining the amount of force or pressure necessary to indent or flatten a small anterior area of the globe of the eye. For your purposes, just know tonometry and know that your normal IOP should be 10 to 21, okay? That's really the main takeaway from here. Okay, so what are they going to be seeing when they have glaucoma, right? So blurred vision or halos around lights is pretty much a classic symptom. Difficulty focusing, difficulty adjusting eyes to low light, loss of peripheral vision, aching discomfort around the eyes, and headaches, right? So remember the intraocular pressure is basically elevated. You don't care the reason why. It could be because of the trabecular meshwork, or it could be because of the angle closure. Manifestations are going to be similar. The angle closure is more acute, so maybe it's going to hurt more headaches, and it's more of an emergency. But in terms of discomfort and headaches, pretty much true for both of them. Okay, so loss of peripheral vision for sure going on here, so they can't see peripheral, right? Tunnel vision, right? So you're losing a whole field here. Okay. So medical management is aimed at preventing optic nerve damage by decreasing your IOP as much as you possibly can. So obviously, if it's an acute angle closure, the IOP might be really, really elevated. So they might need to decrease it by at least 50%, right? If it was really, really severely elevated. And you want to prevent further damage to the optic nerve. So there's a whole bunch of medications, and each of them is doing something slightly different, but the end result is to normalize the IOP, whether it's by decreasing aqueous humor because there's too much production, or whether it's increasing the emptying of the aqueous humor so the IOP pressure goes down. It doesn't matter. It's just all these medications. At the end of the day, they want to decrease that IOP. So you have things like miotics. So they're causing things like pupillary constriction to lower the IOP by increasing aqueous humor drainage. They have things like adrenergic agents. They're decreasing the production, but they're also increasing the aqueous outflow. So cholinergic agents, they are helping with pupil constriction, and they are going to also help with aqueous humor drainage from that context. All right, ignore this, different text. Yeah. So a whole bunch of meds. There's also a chart in your book. So this is just here for you to look at, and just describing these medications. For the instilling eye drops, I'm going to refer you to the one in the chart. I think it's the same information, but go to the one in the chart, look at that closely. The main issues I want you to be able to know is that you're giving the eye drop before the ointment if you have both of them ordered. And if you have eye drop and ointment, you're giving eye drop first. You're going to wait at least 10 minutes, and then you're going to give the ointment. If you have two eye drops, You're giving one eye drop, you're waiting at least 5 minutes, and then you're giving the next eye drop. All right. And I think I messed up because I have the eye drops, then I have medical management, then the next slide is eye drops again. But look at the one in your chart. Okay. If you have a problem with anything, you can just email me. So, if the pharmacologic therapy is obviously ineffective, then we are going to perform surgery. So we've been given just a couple of different examples that they can do under glaucoma. So they can do what is known as a trabeculoplasty. And anytime you see that word plasty, you should know that that's some type of reconstruction. So here, all they're doing is they're widening the canal of the Schlemm, to promote outflow of aqueous fluid. They can also do what is known as a laser iridotomy. An opening is made in the iris to eliminate pupillary block. So this is related to angle closure glaucoma. So just know that these are out there. You should be able to know that they're coming under glaucoma if you see them. This is the slide that goes with the giving the eye drops. Okay. Another example is known as a trabeculectomy. So know that this is out there as well. It's removing part of the trabecular meshwork. Apparently it's minimally invasive, and it's done to also improve fluid drainage. And the main serious complication with this one is increased ocular pressure 2 hours after the procedure. So you just want to monitor the patient closely. And this is a picture of the pupillary block laser iridotomy.